Hey guys, welcome back to my channel, The ENT Resident. Today we'll be finishing up the series on septoplasty. Today is day 3, and today we'll be talking about the different complications of septoplasty, and lastly we'll end with the different approaches that we can possibly have in septoplasty. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, whenever you're asked about complications of septoplasty, we'll not mention random complications in an haphazard manner. We'll first try to classify them. So, how do we classify them? First of all, you can classify into intraoperative and postoperative complications. Then, intraoperative itself can be divided into two types. We have anesthetic complications and we have complications because of the surgery. And postoperative complications can be divided into two. We have immediate postoperative complications and delayed postoperative complications. So, this is what is going to be our base classification of complications. Now, let's talk about each one of them. So, first, let's talk about the intraoperative complications. So, the intraoperative anesthetic complications could be possibly there can be maybe hypotension from adrenaline that you use in the local anesthetic, or maybe the patient has some kind of drug allergy to one of the anesthetic gases being used, or the patient may even end up at a cardiac arrest from anesthesia. So these are all different complications that can happen from the anesthetic side of things, and this will usually be managed by the anesthetist intraoperatively. And these are all things that can be preventable by doing a good pre-operative assessment before even the surgery has begun. So these are the anesthetic complications. Next, coming to the different intraoperative complications because of the surgery itself. First of all, we'll have primary hemorrhage. So we in tonsillectomy we have learned about primary, reactionary as well as secondary hemorrhage, right? So primary hemorrhage is an intraoperative complication. Reactionary hemorrhage will be an immediate postoperative complication, and a delayed postoperative complication would be a secondary hemorrhage. So, primary hemorrhage is the hemorrhage that is occurring at the time of surgery, and this usually happens because of injury to different arteries. Like, for example, the sphenopalatine artery can get injured, or the anterior ethmoidal artery, or the posterior ethmoidal artery, or even the septal branch of superior labial artery. All of these arteries can get injured during the time of surgery, and that can lead to primary hemorrhage. And how do we manage this? We will either manage it by doing packing of the nose, or we can even cauterize the bleeding point. Now, if you see that there is any bleeding happening from the bone in the floor, that can be stopped with the help of either bone wax, or you can do it with the help of packing as well, or a bone hemostat. So that's about primary hemorrhage. And the other complication that can happen over here during the time of surgery is you can end up causing damage to the surrounding structures. For example, maybe during the time of elevation of the flap, you may end up causing a tear in the flap, mucoperichondrial flap. So, if in case you do end up causing a tear to flap on one side, if it's only limited to one side, then you do not have much to worry about. But in case you got really unlucky and the flaps got damaged on both the sides at exactly the same identical points, in that case, that will lead to a delayed complications, which is a septal perforation. So that is something that you should be very careful about when you are performing elevation of the mucoperichondrial flap. That is a very crucial step in septoplasty when you are elevating the mucoperichondrial as well as the periosteal flaps. So these are the different intraoperative complications that you can see, some due to anesthesia and some due to the surgery itself. Next, let's discuss the different postoperative complications. So, as we had seen, we have immediate and delayed post-op complications. First, let's talk about the immediate postoperative complications. As I mentioned, the first one is the reactionary hemorrhage. Now, reactionary hemorrhage, can you tell me what is it exactly? This is the hemorrhage that occurs within 24 hours of the surgery. This number is important for you to remember. This is something very commonly asked if you get a case of tonsillectomy, like what is reactionary hemorrhage? What is the time period during which it happens? This can happen. The cause of reactionary hemorrhage could be due to either the adrenaline wearing off or maybe a rise in BP post-operatively in the patient. Usually, we manage these cases with the help of repacking the nose most of the times. Sometimes you may even need to perform cauterization of the bleeding point. And even if then you're not able to manage it, sometimes you may even need to take the patient back up to the OT and manage it on table. So that's our first immediate post-op complication. Our second complication is headache. Now, why does headache occur? Headache can occur because at the end of septoplasty, we do a nasal packing, right? Anterior nasal packing. Now, if you end up doing a very tight nasal packing, and which is pressing on the turbinates and the septum, because of this pressure, it can lead to the development of headache in these patients. The management is very simple. You either loosen up the nasal packing or you just remove the pack very early. And sometimes even analgesics may be required. Next, a third immediate post-op complication would be having eyelid edema. So, say you have gone to do a post-op round of your patient and you see that your septoplasty case has developed edema around their eyes. What would it indicate towards? So, the first thing you will be thinking is that maybe the nasal packing has been done very tightly. So when you do a very tight nasal packing, what it does is it increases the pressure which is being transmitted via the thin lamina papyracea to the periorbital tissue. Now, this is a very self-limiting condition. You do not have to be super worried about it. You just have to remove the pack and then it will resolve by itself. So these are two common things that happen because of the tight nasal packing done at the end of the surgery. And the last immediate postoperative complication is infection. So the packing of the nose may result in infection of the nose and paranasal sinuses and even the middle ear. So these were all our immediate complications. Now let's move on to discuss the delayed postoperative complications. So first of all these delayed postoperative complications that we'll be talking about, most of them occur more often in SMR than in septoplasty. That's because SMR is a more radical surgery, whereas septoplasty is a more conservative procedure that we do. If you want to know the differences between SMR and septoplasty, I have a separate video on that. You can check it out over there. So first, let's talk about our first one, which is secondary hemorrhage. Now, secondary hemorrhage, this occurs, the main cause of this occurs because of infection. So, our management over here would be to treat this infection with the help of antibiotics. And sometimes even you may need to repack the nose. So, that's our first delayed complication. Next, now, if we look at the nasal septum, sometimes this is the nasal cavity, this is the nasal septum. Sometimes what can happen is if you have removed a lot of the cartilage, there's a lot of open space, there can be a collection of blood on both sides of the septum, leading to something like this. If we look at the third image over here, we can see that there is a bilateral septal swelling that we can see over here. Now, this is the collection of blood between the cartilage and the mucoperichondrium. And this can even occur when the flaps have not been approximated properly after surgery. So you'll see this smooth fluctuant swelling, which is blocking both sides of the nose. This is your septal hematoma. Now, septal hematoma, the way to treat it would be to drain it out immediately. Either you perform an aspiration or you do an incision and drainage. Now, if this septal hematoma has not been drained at the right time, then what will happen? It will lead to another complication. So, because the cartilage is not getting any blood supply because of the swelling, this will lead to infection of this swelling and development of what we know as septal abscess. So septal abscess happens when the hematoma gets infected, which was not drained in time. So over time, this gets infected and pus starts collecting between the flaps. Now, this patient will present to you with fever, and they'll have a fluctuant swelling on both the sides, and they'll also have severe nasal pain. The treatment at this point would be to start the patient on IV antibiotics and do a incision and drainage. Now, again, say you have not treated the septal abscess also at the right time, and this has gone on for a long time. This will lead to necrosis of the cartilage, and that will lead to our next complication, which is septal perforation. So let's look at the image over here. This is what a septal perforation will look like. So if you have not treated the septal abscess, the cartilage will get necrosed, and that will lead to a perforation in the septal cartilage, leading to the development of the septal perforation. And this can also happen because earlier I mentioned, if the mucoperichondrial flap gets torn the exactly same identical side on a site on both the sides, that can also lead to the development of a septal perforation. Now, what do we do in this case? How do we manage it? If it is a very small septal perforation, possibly the patient will complain of a whistling sound on breathing. Most of the time, these can be left alone if it's not too troublesome. But if there is a large perforation, it will lead to crusting, epistaxis, and even nasal obstruction. In that case, this will need surgical closure with the help of flaps. So these were some of the delayed complications. Next, we have the development of synecdoche or adhesions in the nasal cavity. If you look at the first image over here, this is what a synecdoche looks like. How does this happen? Some adhesions, if you say during the time of surgery, if you end up causing injury to the septal flap, as well as the turbinates on the lateral wall at the exact identical site. So you have basically you have done is you have left raw mucosal surfaces on both sides of the nasal cavity. So these will join up together to form adhesions, or what is known as synecdoche. This is now a very preventable complication. How can you do that? How can you prevent it? We should be very careful about not causing much injury to the mucosal surfaces. That is important. And secondly, if you do a proper packing post-operatively, this can be easily prevented. Now, usually if these are asymptomatic and the patient does not have any issue, there is no treatment required. But if the patient is complaining of nasal obstruction, in that case, you have to release these adhesions and you have to keep the raw edges apart using silastic sheet for at least 10 to 14 days. So that's about synecdoche formation or adhesions. Next, let's look at this image over here. So we have the caudal strut. We know the L strut, right? The L strut that we should be preserving during surgery. So this is the caudal strut and this is the dorsal strut. Together they form the L strut. Now say you have ended up removing too much of this caudal cartilage. If too much of the caudal cartilage, caudal support is removed, in that case, it can lead to the development of what we know as columellar retraction. So this is our next complication, a columellar retraction. This is very common after a transfixian incision where too much caudal cartilage has been removed. So the columella, it will appear like as if it's been pulled upwards and the nostril kind of look very exposed. This will need a reconstructive rhinoplasty to correct it. Next is another deformity that can form, which is known as the saddle nose deformity. Saddle nose deformity will happen because this dorsal strut that we have, if we do not maintain enough dorsal strut, if the dorsum collapses because of the loss of cartilaginous support, because of too much cartilage removal, that will lead to the development of saddle nose deformity, which is shown in this image over here. This is what a saddle nose looks like. Again, these are all complications which are more common in SMR than in septoplasty. If this happens, you need to do a dorsal augmentation with the help of a cartilage or a bone graft. Next, another deformity that can happen is a supra-tip depression. So if the area just above the tip of the nose loses the support, the cartilaginous support, that area can become depressed. And this usually happens if the upper lateral cartilage attachment to the dorsal septum has been disrupted. Again, in this case, you have to correct it by doing a grafting. So these were some of the delayed complications. There are more. Mm, the patient can complain to you of a persistent or a recurrent nasal obstruction. So you have performed a surgery maybe to correct the nasal obstruction, but you see that the patient continues to complain of a nasal obstruction. In that case, you have to determine what is the cause behind it. Maybe the deviation has not been corrected fully. Maybe there is some residual spur which has been left behind, or maybe there is a turbinate hypertrophy, a mucosal turbinate hypertrophy, or a bony hypertrophy which has not been addressed. All of these cases can also cause this. It can even happen because of synecdoche development. So you have to perform an examination of the nose and find out what is the possible cause for it and appropriately take the management. Maybe you need to do a revision septoplasty, or maybe a turbinate reduction is required, or maybe the patient needs to be put on some anti-allergic treatment. So those are all the causes for persistent or recurrent nasal obstruction after septoplasty. Next delayed complication is development of a CSF rhinorrhea. And this is a very rare complication, but in case it happens, it's very serious. This can happen if the perpendicular plate of the ethmoid somehow that gets damaged or avulsed. And this usually has a very conservative management where you put the patient on bed rest, head elevation, and if it does not improve over the next few days, then you perform a surgical repair after it. And lastly, our last complication is a toxic shock syndrome. And this is a very rare complication. This can happen because of nasal packing being left too long, which leads to because of staphylococcal exotoxin getting released from there, leads to toxic shock syndrome, where the patient will complain of high fever, diffuse rash formation, hypotension developing. If indeed this develops, this is a total medical emergency, and you have to treat it by removing the pack, starting the patient on IV antibiotics, and ICU management would also be required. So this is all about the different complications of septoplasty. I hope you have understood it, and we will approach it in a very systematic manner by dividing it into intraoperative and postoperative complications, which intraoperative itself can be due to anesthesia, due to surgery, and postoperative can have immediate and delayed complications. So these were all the different complications of septoplasty. Next, let's talk about what are the advantages of performing septoplasty. First of all is that this is a surgery that can be very safely done in children after the age of 4 years. Whereas SMR is something that you cannot do in young children. Second, this is also a surgery of choice in case of caudal septal dislocation. Killian's incision is given in SMR, which is basically given a centimeter behind the caudal end of the septal cartilage. So you cannot do an SMR for a caudal septal dislocation. For that, only septoplasty is the operation of choice. Next, because septoplasty is a very conservative procedure, it preserves enough support to the cartilaginous vault of the nose. And septoplasty can be easily combined with rhinoplasty. The incision that we use in septoplasty is usually the Freer's incision, also known as the hemitransfixian incision. But this incision can be easily converted into a transfixian incision, which is required in rhinoplasty. And lastly, revision surgery is really easy to do in septoplasty because this has been a conservative procedure. So these are the different advantages of performing septoplasty over SMR. Lastly, let's talk about what are the different approaches that we have towards septoplasty. So first one is the very common one that we practice the most in today's times, which is conventional technique using the headlight. This is what we have been widely practicing. But something that has been gaining more popularity recently is doing a endoscopic septoplasty. And in endoscopic septoplasty, we use a 0-degree 4-millimeter telescope. And this has been gaining a lot of popularity recently because it gives you certain advantages. Now, the advantages are, first of all, it gives you improved visualization because you're using the endoscope. You're able to visualize the whole nasal cavity much more easier than when you use a headlight. with the conventional technique. So you're able to even see posterior septal deformities more easily. Second, it allows minimal access dissection to reach isolated deviated parts of the septum, which would be much more difficult to reach using the conventional technique. Third, you can easily combine this with the sinus surgery or the functional endoscopic sinus surgery. And fourth is this has much reduced morbidity and postoperative swelling and isolated septal deviation because you can easily limit the area of dissection to just the area of the deviation. So endoscopic septoplasty has been gaining a lot of popularity in recent times over the conventional technique. And then we have two more approaches. The first one is the external or the open approach septoplasty. Now, this external approach is usually indicated when there is severe deformities of the ventrocaudal septum. Also, in cases of total septal cartilage removal and transplantation. And this will also be preferred if there is a external nasal deformity that requires correction along with the septal deformity itself. In this case, we give a bilateral marginal and transcolumnar incision. We elevate the nasal skin after decortication. Then the nasal septum is approached in between the medial crura. We elevate the mucoperichondrium and reconstruct the septum. So this is our external or open approach septoplasty. Lastly, we have the extracorporeal septoplasty. Here, what we do is we remove the entire septal cartilage, we reshape it back on the table, and then we reinsert it back again. That is why this is known as extracorporeal septoplasty, because we are taking it out. This is primarily used for severely deviated or twisted septal cartilage, and this actually has a very high risk of developing a septal perforation and saddle nose deformity. So these are the different approaches to septoplasty. I hope today's class has been very clear and you have understood everything. If you have any questions regarding this, please note them down in a comment section and I'll get back to you. Thank you.